Thank you so much, and thank you so much for inviting me here today and for staying at the end of this conference in Montreal. I first want to acknowledge that I am on the unceded and traditional territory of the Gagne Gahaga, a site of meeting and exchange among many First Nations who are the traditional custodians of these lands and waters. So an overview. How am I going to discuss the social determinants of health and HIV among youth in high and low income contexts? That was a big task. So I decided I'm going to start with just 3 case studies and try to provide an overview of some considerations. The first case, and from our team's research, the first case is with refugee adolescents and youth in Uganda. The second is with Northern and Indigenous youth in Northern Canada. The third is LGBTQ youth in Jamaica. So I'm going to start at the end. So this is the answer. So this is all you get? It's fine. So here are some key considerations when thinking about what shapes both engagement with the HIV prevention cascade, from testing to uptake of various prevention modalities to the HIV care cascade. The first is a concept of ecosyndemics. So many of you probably have heard about syndemics, the clustering and interaction between biological, social, and psychological health challenges that exacerbate negative health impacts. So ecosyndemics, as defined by Singer, is how conditions for poor health are more likely to occur under unstable environmental conditions coupled with economic inequalities. So it adds the environmental, ecological aspect to thinking through syndemics. The second is intersecting stigma. This refers to interlocking social categories such as gender, sexual orientation, race, and class, and how they are linked with inequitable access to power and life opportunities for people to realize their potential. The third is resource scarcity, how structural level factors and ecological factors contribute to community level water and food insecurity, and how these in turn affect mental, physical, and sexual health, stress, and suffering. Fourth is cumulative and chronic violence. This includes violence in conflict, communities, families, and intimate partnerships, spanning childhood, adolescence, young adulthood, into adulthood. And finally, constrained rights and agency. This refers to access to self-determination, justice, and rights. And this is not experienced equally. It varies based on citizenship status, gender inequity, LGBTQ identities, and the criminalization of sexual orientation, gender identity, and sex work, for instance. So that's the answer. So I'm going to start off with the first case study. It's based on the last 5 years of multi-method, community-based research I've done in partnership with Ugandan community-based organizations, ministries of health, and a wonderful research team. It's included qualitative, quantitative, and intervention research, as well as a cohort study, and randomized control trials working with refugee adolescents and youth aged 16 to 24 in Kampala, Uganda, as well as in Bidi refugee settlement. For those who may not know, Uganda is Africa's largest refugee hosting nation right now with 1.5 million refugees. And I just want to note that I'm not going to be going into the depths of all of the study design. We've published quite a few articles detailing different methodologies, so I'm happy to share those with you, and some of them are listed as references. My point is to cover conceptual issues and our high-level overview of findings. And so I'll be briefly touching on our findings that span these social determinants of health in this context, specifically around intersecting stigma, food and water insecurity, violence, and pandemic-related disrupted sexual and reproductive health care. Our qualitative findings, and this is an example of one of them, align with the health, stigma, and discrimination framework to really underscore that among urban refugee youth in Kampala, and I argue in many different contexts, what matters when we consider engagement in HIV testing is really thinking about the drivers and facilitators of stigma, that include fear of infection and misinformation, judgment, inequitable social and gender norms, as well as a legal environment and peer support. Urban refugee youth discuss with us stigma linked with being a refugee, being a sexually active adolescent or youth seeking sexual and reproductive health care. We have published, as have others, on adolescent sexual and reproductive health stigma and its linkages with lower uptake of HIV testing. And it's really something that I think needs to be included in more research, adolescent sexual and reproductive health stigma. And we actually found that it was a stronger correlate of not testing than HIV stigma. Sex work, sexual orientation, and gender inequities, as well as HIV stigma. These resulted in mistreatment, fear, shame, blame, and coercion regarding HIV testing in intimate partnerships, families, communities, police encounters, and in health centers. Ultimately, they reduced engagement in any testing, and for those who had negative experiences with testing, they resulted in not wanting to further engage. These findings align with a larger literature on intersectional stigma rooted in Black feminist theory that examines the oppressions that occur at the intersection of multiple forms of marginalization, as well as opportunities for social support, solidarity, activism, and resistance, which we've also documented in various contexts in the world, including with women living with HIV in Canada. Stigma research is really evolving to be intersectional and to look at multi-level social ecological manifestations of stigma. I also want to note that we found that food insecurity was a chronic, prevalent factor in our cohort of urban refugee youth. Before the pandemic, it affected nearly 60% of youth in our sample and 65% of youth during the pandemic. And it was associated with depression, lower HIV testing uptake, and increased engagement in transactional sex. This corresponds with a robust body of evidence that shows food insecurity as a driver of HIV via transactional sex and survival sex. And anybody who's been reading the latest World Food Program reports will know that food insecurity has increased during the pandemic and is of urgent concern for people's life and well-being. We also found that violence was a chronic and cumulative experience with this cohort of urban refugee youth. More than half experienced violence at the age of 16 or over, which we refer to as young adulthood violence. And among those in relationships in the past 12 months, most, 86%, reported any form of intimate partner violence. And this was higher for those who experienced childhood abuse. In our recent paper, we found that there was an interaction between frequent alcohol use and intimate partner violence on sexual risk factors, including recent multiple sex partners, recent transactional sex, and there was an interaction between young adulthood violence and depression on transactional sex. This syndemics approach suggests that we could address problematic alcohol use, depression, and/or violence, and it may also reduce HIV vulnerabilities among urban refugee youth and likely among many other youth who experience similar syndemics. Food and water insecurity in the pandemic were also widespread and linked with HIV vulnerabilities. I've already noted the high prevalence of food insecurity in this cohort, but 47% reported water insecurity. In adjusted analysis, water insecurity was associated with 2.5 higher likelihood of reporting unplanned pregnancy, 2.7-fold higher likelihood of transactional sex, as well as reduced sexual relationship power and reduced condom efficacy. Food insecurity was also associated with disrupted sexual and reproductive health access. And similar to other findings coming out of Kenya with women living with HIV, we also found water insecurity was associated with double the odds of food insecurity. This aligns with an increased focus on climate change and HIV, and in particular drought and water scarcity, on HIV risk via pathways of migration, survival sex, and poverty. There's a poster with these findings that you can find at AIDS 22. 2022. And so finally, I really want to note the importance of considering the COVID-19 pandemic as a social determinant of health and a driver of HIV risk. We found that 30% of youth in this cohort reported reduced reproductive health service access in the pandemic, including oral contraceptives, and 30.6 reported reduced sexual health services, including condoms, HIV, and STI testing. During this pandemic, among the sample of 440 youth, 1/10 of young women reported unplanned pregnancy, and 10% reported transactional sex during the pandemic. Disrupted sexual and reproductive health care is due to a constellation of factors, including increased poverty, reduced money to travel to clinics, lockdowns, and clinic closures, and or focus on COVID rather than other services. Finally, I do want to note some positive findings. We conducted an RCT of an HIV self-testing study where one arm also received HIV self-testing with mHealth support with this cohort of urban refugee youth in the pandemic. It was the first time HIV self-testing has been implemented with refugee youth or refugees at large, and I'm part of the WHO guideline for self-care interventions for sexual and reproductive health and rights, and we have been writing about humanitarian contexts and increasing access to sexual and reproductive health self-care interventions such as self-testing. These findings, which are in review, are highly significant. HIV testing increased at baseline in the HIV self-testing arm from 28% to 98% at 8 months, in the mHealth and the mHealth plus HIV self-testing arm from 30% at baseline to 94% at 8 months, compared with the standard of care, which was referring people to clinic-based testing, which did not really significantly improve at all, from 35% at baseline to 36% at 8 months. We verified HIV status knowledge by point-of-care testing, and we also found significantly higher knowledge of one's HIV status in both intervention arms, 100% and 98%, compared to 61% in the standard of care arm. And we also noted that youth in the HIV self-testing plus mHealth arm had lower adolescent sexual and reproductive health stigma scores, and those in the HIV self-testing alone had higher HIV stigma and adolescent sexual reproductive health stigma scores. So mHealth could thus have a protective role in buffering stigma for youth engaging in HIV self-testing. Very briefly, I'll discuss our work for the last 3 years in BDBD, refugee settlements, one of the largest refugee settlements in the world with 240,000 residents, largely from South Sudan and to the border of Uganda and South Sudan. Our mixed method study began with qualitative methods, finding gender inequities such as violence, forced early and child marriage, and poverty linked with food, firewood, and water insecurity, and chronic traumatic violence. We developed a participatory comic book based on the qualitative findings to increased post-rape care, including increased PEP awareness and acceptance, reduced sexual violence stigma, and increased bystander practices to safely respond to violence. Our recently published findings noted that we reached these goals among a sample of refugee adolescents and youth aged 16 to 24, and among a small group of healthcare providers, we also found increased youth-friendly service provision and bystander efficacy. We are now integrating participatory comics aligned with the HIV prevention cascade with refugee youth in this context to support an HIV self-testing randomized control trial. These comics include trauma and violence-aware decision-making for partner testing, because there has been instances of women being killed by their husbands in partner testing with adults in this context, as well as stigma reduction. So, case 2. I'm going to briefly share some research with Northern and Indigenous youth in the Northwest Territories, or NWT Canada, where I've been working since 2014 in collaboration with the co-principal investigator, Dr. Candice Liss, who co-founded FOXY, the acronym for Fostering Open Expression Among Youth for Young Women and Gender Diverse People, and SMASH, which is more recently founded, Strength, Masculinities, and Sexual Health, is what that acronym stands for, which are arts-based sexual health programs for Northern and Indigenous youth. Our qualitative and quantitative findings over the years have highlighted the social determinants of health and HIV among Northern and Indigenous youth include food insecurity, alcohol and drug use, depression, violence, and sexual relationship power, all of which need to be understood through a lens that considers the intergenerational impact of colonization and residential schools, which were the highest per capita in the NWT, as well as disconnection from culture and land, and from a strength-based lens that examines culture as healing and empowering, which is what Foxy and SMASH do. We have consistently tried to document the influence of structural, contextual factors, such as food insecurity, among Northern and Indigenous youth aged 13 to 18 and their condom use and self-efficacy, as well as depression, and the interplay I discussed earlier with syndemics between food insecurity, depression, substance use, and HIV vulnerabilities. For instance, this is quite a complicated to figure. This is one of our latest analyses and review that looks at the pathways from food insecurity to lower resilience and increased depression to reduced safer sex efficacy. Addressing food insecurity in the high-income context of Canada remains an urgent concern and human rights issue for Northern and Indigenous people, as well as all people in this context. We also found that LGBTQ stigma, discrimination in larger contexts of heteronormativity and cisnormativity, the expectations and assumptions that everyone is or should be straight or cisgender, negatively impacted sexual and physical health and mental health among LGBTQ youth in the NWT, and these were exacerbated by the rurality and the lack of options for healthcare in rural and remote communities. As I mentioned, Foxy and SMASH, both open to gender diverse youth, hold school-based workshops that integrate multiple arts-based methods, including body mapping, theater, role play, and elders' teachings, working from a sex-positive framework, as well as peer leadership, with land-based retreats with traditional teachings that are actually happening right now, today, at a fly-in lodge in the NWT, where there's beading, drumming, land-based learning, elders, and we have found these are linked with increased safer sex efficacy, HIV and STI knowledge, healthy relationships, empowerment, and leadership skills. So the final case I'm going to talk about is our ongoing research with LGBTQ youth aged 16 to 24 in Jamaica, a long-standing collaboration with Jamaica AIDS Support for Life, which is the oldest AIDS service organization in Jamaica. Since 2013, we have documented HIV stigma and LGBTQ stigma and criminalization, as well as sex work stigma and criminalization as social determinants of health and HIV risk for young LGBTQ persons. Building on this HIV prevention work, we started a qualitative study with LGBTQ youth and young sex workers living with HIV in Kingston, Montego Bay, and St. Anne. Our key findings, as noted here, include intersecting stigma, including HIV stigma linked with low treatment literacy, such as fear of infection and assumptions that people with HIV are, quote, already dead, LGBTQ, and sex work stigma. These create profound barriers to accessing and taking medication and result in isolation. We're isolated after family and friend rejection from both HIV and from sexual orientation, gender identity, and sex work. And this, in turn, lowers self-esteem and harms mental health. And there are barriers, financial barriers, economic barriers to accessing safe housing, insufficient food, and secure employment. And these also present barriers to taking medication and to living a good life. I'm going to put on my glasses to read you some quotations now. So I just want to share some words from community members that were interviewed. A young gay man living with HIV in Montego Bay described, they don't know that HIV is not a killer like cancer, so HIV is just a thing that they scorn, and being an MSM in Jamaica, that is the first stigmatization. Sex workers, they also class or judge those people. A trans woman described having to get an HIV test for employment, and she said, when I went in and did the test and they found out I have HIV, they said I can't get the job anymore. In my mind, I wanted to kill myself because I kept saying, what is this? It's like as if your life is over. My life is done. And I can't tell you the number of times people discuss suicide in our interviews with more than 30 people. And a sex worker described, the nurse said my daughter can't use the same sheets and towels that I use. She can't use the same bar soap that I use to bathe with or the plates and utensils. This is very common. This was not just in St. Anne. We heard this in Kingston. We heard this in in Montego Bay. I said, what am I living for? I should just go to the beach and dive off. So I went to the beach and dived off. Trust me, I'm not telling you a lie. Based on these findings, we created a comic series that spanned the HIV care cascade from testing to diagnosis to adherence to living positively with HIV. We created blank versions that were then used as an interview tool with young LGBTQ persons and sex workers, including 30 in each site, so it's 90 interviews that we just finished conducting. This is an example of a comic that shows many of the themes we found regarding medication adherence barriers: hunger, no transportation funds to the clinic, stress about telling one's partner about one's status, and confidentiality concerns at both clinics and pharmacies. This is my favorite comic that also reflects findings on the ways that young people are living positively with HIV, including accessing support groups, connecting with friends, taking medication to look good, living for their children, and inspiring other people in the same situation as themselves. Here's an example of how participants filled the comics out themselves after looking at the ones that were created. Moving forward, and this is an image from a comic book we made in Uganda, actually, our colleagues in Jamaica want to focus on the strategies identified for living positively with HIV among young people to inform future interventions. To sum up, we have talked about access to resources, power, and survival needs. These concepts help to encapsulate some of this thinking around ecosyndemics, how ecological, social, and physical environments interact with health issues and inequalities to increase HIV vulnerabilities. We talked about intersecting stigma, including adolescent sexual and reproductive health stigma that is understudied, concurrent resource scarcity, including food and water insecurity, and the impact of climate change, and these are also understudied in the context of HIV risks and care cascades. We talked about violence as chronic and cumulative, and we talked about constrained rights and agency, including sexual relationship power and sexual self-efficacy, and legal barriers towards LGBTQ people, sex workers, and refugees. But I want to leave with a note on critical hope. Critical hope is how we find hope for change in the midst of injustice, how actually injustice can fuel our endeavors and our work together for social justice and for equity and change. Let's think about some other determinants of health and well-being. These include flourishing. What does it mean to live a good life? Social and community connectedness and solidarity. Multi-level resilience, so not just individual resilience, but collective resilience. And this very useful concept of sexual well-being. I took this figure from a recent article by Mitchell in The Lancet that looks at sexual well-being as inclusive of sexual respect, sexual safety, sexual self-esteem, and sexual self-determination. This is a critical facet linked with sexual health, but extending beyond it. I'm a huge proponent of sexual pleasure and sex positivity, so increasing access to LGBTQ and sex work inclusive, comprehensive sexuality education. The work of the Pleasure Project, if you've never checked it out, by Annie Philpott, is very inspiring and documents the sexual health benefits of sexual pleasure. The World Association for Sexual Health has a declaration on sexual pleasure, and I encourage you all to read it. It highlights sexual pleasure as integral for sexual health promotion and for comprehensive sexual education and services. In my last 15 seconds, I would like to thank the enormous amount of collaborators, partners, community, participants, peer research assistants in Uganda and NWT in Jamaica, University of Toronto, all the funders, the artists, and feel free to contact me and check out our website. Thank you so much for listening.
Thank you so much, Carmen. I mean, this has been quite a very eye-opening presentation. She's taken us to 3 different countries in different areas, Uganda, Canada, and Jamaica. And her presentation does tell us that there are disadvantaged and low-resource areas in high-income countries, and there are advantaged and high-resource areas within low-income settings as well. So we need to think about these things beyond. They are not homogeneous places. So at this point, I'd like to invite any questions that people might have for Carmen.
to time.
Yes, you did.
I was exactly on time.
Hello,
Okay.
Valérie Lamar from Montreal, here, from Saint-Justine. I've been wondering for a long time, a lot of us don't call our clinic by their real name. You know, we make up acronym not to say HIV, not to name it. And I've been wondering for a long time, are we making things worse? Like, it is so bad that we don't even name it. So I know we're all doing it out of defending the people, intimacy and secret and all that, but are we making things worse by not naming things? I don't know of a cancer clinic that calls itself the Funny Cells Clinic or something. You know, they call themselves oncology clinic. So, like, are we making things worse is my question.
I think that we live in a stigmatizing society, so I think if clients are preferring a neutral named place versus an HIV clinic and it makes people feel more comfortable to go, then we should be led by what the clients want. But I think what you're speaking to is a lack of funding and engagement in changing community level stigma. The reason that people don't want a clinic named HIV clinic is because of the stigma they're experiencing in larger societies, in families. And if we, naming the clinic, it's not really getting to the root of the problem, right? It's it's literally kind of the surface level name, but the real issue is we're not funding and we're not resourcing real community level stigma reduction because it's complicated and it's expensive to change hearts and minds in societies. So I think, if we're thinking about the individual clinic and the name of it, I think where maybe the focus should be on how do we actually look at what stigma looks like in the community and we change community norms so that it doesn't matter if it's linked or not. Because I've seen whenever there's an HIV specific room or building, people will do anything to go around it in the dark, to not be seen going there, anywhere. I was just in Kenya 2 weeks ago in a refugee settlement, and they were like, oh, there's the HIV building, but nobody goes there because you know that you have HIV if you go to that building, and people don't want to have that stigma. So I think until we can really grapple with changing community level stigma and social stigma, we're probably going to need to try to reduce at least the experiences of stigma people get going to a clinic. So I think what you're raising is just kind of signaling a lot of deeper issues.
Thank you, Carmen. Batu?
So thank you. That was really magnificent. I have a little question for you, which is about the use of cartoons, because we've done that in a number of projects, and they're very labor intensive to develop, and then you're often, left with materials that you need to update. And I'm curious as to your experience and whether you've tried other modalities as well.
Definitely, it's a great point. And we're doing virtual reality right now. That's way more intensive, trust me. I'm like going back to comics. We've done videos. We've done other things using really arts-based methods like collage and mirrors and those type of work. We started doing the comics actually as a Grand Challenges Canada project, and they were supposed to be participatory, but then the pandemic happened. So it was still participatory over Zoom of getting images and feedback and working that way. But the youth loved it so much, they were like wanting it for friends. But we do it in 5 or 6 languages. It's really labor intensive to do a comic in 5 languages. So we have it in 6 languages in Kampala, so all different languages. But people like them, and they seem to be, some of them are more text heavy than I would like, but because they're completely theoretically informed. So we have like our theoretical model of change, and we map onto it. So what are the scenarios? And we do that with we work with communities, and we work with young people in all of our projects that are telling us, like, oh, you need a comic on this. And we also showed it with elders. So we've actually been engaging elders in our research too. And so there's all of our comics are open access. They're on our website. You can download them. You can use them. If you would like it in a different language, if you have the language you want it done in, we could, it's not that expensive to add a different language at this point. So we're kind of using those now because they seem to be a bit sustainable. We also laminate them so we can clean them and leaving them in health clinics so that people can just have them around at the health center. So it seems to be that, but we are making more videos too. So, and the virtual reality, which is a whole other story. We'll talk about that another day.
Thank you. Next, please, Joey.
No, thank you, and thank you for a very interesting and comprehensive overview of the work that you've been doing. It left me thinking we have a big challenge in trying to address everything you talked about, but I just wanted to ask one question around 3 different countries, very diverse in terms of how services are delivered. Increasingly, we've been talking about social protection or social welfare and how it interplays with delivery of healthcare. And I'm just wondering whether, what you can tell us about how these things are working across the 3 countries.
By social protection, do you just mean provided by the state or provided by communities?
I think increasingly, just wanted to say, increasingly, many governments are trying to do it from a systems approach to overlay some of these support mechanisms over health. And I'm just wondering your experience, because you talked about poverty and food insecurity and all that. And so even if we deliver a very good healthcare program, if these things continue to be issues that we need to address, we've seen that uptake may not be that great because people are worrying about something else. So I'm just wondering whether there's any progression in that area of interfacing healthcare with social support.
Yeah, I could say something to that. For the situation, I mean, Uganda is the best place, to be a refugee compared to neighboring countries and probably even compared to many other countries in the world because it has freedom of movement. So for instance, compared to Kenya, which is now just having a new law that people can apply for a work permit. But in Uganda, people are free to move outside of the refugee settlement. But when they do, they give up any access to the economic support that you get from UNHCR and the World Food Program in the refugee settlement. So you do find that a lot of urban refugees experience language barriers in trying to access employment, and a lot live in informal settlements, mostly like slums. So there's some challenges accessing kind of financial support outside of the refugee settlement for refugees. And I'm going to say I was just in BD in March, and meeting with UNHCR, meeting with the World Food Program, and I'm sure you're aware the World Food Program has had to cut rations of food to refugees. So the social support social protections people are getting something like, at least in BD, is about 5 kilograms a person a month. And in Kenya, they're getting 1,500 shillings a month, which is a really small amount of money for refugees to live off. So the social protection is just not sufficient. I know in Jamaica Aid Support did try to have food parcels, but we've had long conversations about sustainability and what would that look like, what kind of sustainable livelihoods or economic empowerment. How do you do economic empowerment in a context where it's criminalized to be LGBTQ, when people can fire you or not hire you based on your sexual orientation and gender identity? So there's a lot of these structural barriers that kind of get in the way of benefiting from economic programs. And in the North, you know, the more I have conversations with people, I realize how complicated it is, food insecurity issues in the North. And there are people spending their life working on it because there's a lot of food being shipped up. There's a lot of loss of land and traditional ways of getting food and hunting, and the climate change. So it's really complex. And I would say that most people in Canada would agree that any social protection we give to people is insufficient for people to live. And the cost of food in the North, you could Google the cost of food in NWT or Nunavut. You could spend $20 on a bag of lettuce. I'm not exaggerating. So the cost of food is really, really high. So we need some other transformative ways of thinking about food sovereignty, food justice. So those are really big issues that I don't claim expertise on, but I want to get more knowledge of, because I agree with you. Unless we're addressing survival needs, it's really hard to address HIV.
And thank you very much, Carmen. I'm sorry we can't take any more questions because we have to go to the next session. But thank you so much for your insights.